Sir. Now it's my pleasure and privilege to invite Dr. Kiran Gopalakrishnan, and he's going to tell us about practical pearls from landmark trials. Dr. Kiran, please.
Kiran, just a sec. There are enough time at the end for question answers. I would request the audience to please jot down your queries. You can either use the mics in the aisle or hand it over the pieces to Dr. Nayak, who will be chairing the question answer session also. Go ahead, Kiran.
Yeah, good afternoon, everybody. So I have the enviable task of covering 7 landmark glaucoma trials in the next 7 minutes and try to glean practical pearls from them. We will start with the ocular hypertension treatment study, which addressed the question, do we need to treat ocular hypertensives? Patients were randomized into the medication and the observation arm. The observation arm were put on medications at 7.5 years and followed up for a net period of 20 years. The headline results were that the risk of conversion to glaucoma could be reduced from 9.5 to 4.4 at 7 years, and at 20 years, the results were 49 to 42%. So from a practical perspective, it is pretty obvious that all the ocular hypertensives do not require treatment, because only an extra 8% gets protected from glaucoma if we treat. All ocular hypertensives are not alike. This is a well-known depiction from the OHTS trial that tells you that patients with low baseline CCT and high IOPs are at much higher risk of progression compared to ones with opposite parameters. And you can use the OHTS calculator for objective stratification. It's important to do both structural and functional testing in ocular hypertensives because more than 55% of patients with optic disc changes had no concurrent visual field changes. The EMGT looked at effectiveness of IOP lowering in reducing POAG progression. Patients randomized into observation and treatment, which was a fixed regimen of ALT plus betaxolol in keeping with the times. And the headline results were that the risk of progression could be reduced from 62% to 45%. From a practical perspective, treatment was beneficial across a wide spectrum of POAG. So it was effective irrespective of the IOP being lower or greater than 21, and was effective even when the field effects were slightly milder or slightly greater of more than 4.5 decibels. Now, all POAGs like ocular hypertensives were not alike. Some of them did progress faster, and the predictors of long-time progression included exfoliation, thin CCT, disc hemorrhages, presence of some vascular factors like low systolic perfusion pressure, low systolic blood pressure, and cardiovascular risk. The collaborative normal tension glaucoma trial looked at the effectiveness of IOP lowering in NTG, patients randomized into the observation and treatment arm, which aimed for an aggressive 30% reduction of IOP from baseline. And the results were that the risk of progression could be reduced from 35% to 12%. And the practical pearl from here is that most NTGs do not obviously need treatment, simply because 65% did not progress over 8 years despite no treatment. And keep in mind that the study only recruited severe or progressive NTGs. The mild to moderate NTGs that you see in the clinic will not have the same rates of progression as the study showed. The collaborative initial glaucoma treatment study looked at the choice of whether we should treat newly diagnosed POAG medically or surgically. The patients were randomized to receive either medication or surgery, which involved trabeculectomy with or without 5-fluorouracil. And the headline results were that both the medication and the surgical arm were equally effective in visual field preservation over a 9-year time frame. From a practical perspective, the standard approach of starting medical therapy and, if ineffective, shifting to surgery is actually effective, because not only were the visual fields preserved between the two groups, over 9 years, the quality of life was also similar in general between the two groups. But you should have a lower threshold for surgery in advanced glaucomas, as in the subset of advanced glaucomas, surgery fared far better than medications. The advanced glaucoma intervention study looked at advanced POAGs and looked at 2 treatment sequences, one starting with trabeculectomy and the other with ALT. And in the results, the patients were divided into 4 different groups, A to D, based on 2 parameters: average IOP in the first 18 months, which is a marker of early IOP reduction, and percentage of visits with IOP less than 18, a marker of consistency. Group A was the star, with less than 14 millimeters of mercury in the first 18 months and 100% of visits having IOP less than 18, and had practically no progression of visual fields over the 7 years of time frame. From a practical perspective, in advanced glaucoma, therefore, the risk of progression can be minimized by both early aggressive IOP reduction and sustained IOP reduction across all visits. But keep in mind that 18 millimeters of mercury is not a magic number, because in this group, the mean IOP was only 12.3, and despite this low IOP, 15% did worsen by 7 years. The tube versus trabeculectomy study looked at whether you should trap or tube eyes with prior ocular surgery. Patients randomized to receive either trap or a bowel tube. The results were that at 5 years, a higher failure rate was observed in trap, and also a higher rate of early post-op complications dominated by wound leaks and hyphema. But the rates of late postoperative and serious post-op complications were the same. From a practical perspective, you can probably expect even better results with tube with eyes with more prior complex surgeries, because the TVT only recruited prior cataract surgery eyes, which does not have an impact on the conjunctiva, and failed traps. Prior keratoplasties and prior vitrectomies might give better results with tubes. And valved implants like AGV may not offer the same success rates, because they generally tend to have higher IOP but have lower hypotony-related complications compared to the bowel tube used in the study. The primary tube versus trabeculectomy study addressed the same question, but in eyes with no prior ocular surgery. We again patients randomized to receive trap or the bowel tube. The results were that at 5 years, if you define failure as IOP greater than 21, traps and tubes were similar. But if you redefined IOP at 17 millimeters instead of 21, traps generally had better success rates than tubes, though it did not approach statistical significance. From a practical perspective, though the rate of IOP reduction between traps and tubes were the same at 5 years, trap was able to offer the same results with fewer medications. Therefore, the rate of complete success was actually higher in the trap group. Therefore, this becomes a default choice, especially in patients with poor compliance and intolerance to medications. I thank you for your patient listening.
Thank you, Dr. Kiran, for giving at least brief, whatever the takeaway messages.